Hi, Kristi Kane from ElderCircle Forum. Join me later as I speak with Tim George from Meds One EMS about community paramedicine in Itasca County. Tim, tell me a little bit in short about community paramedicine and what it does.
The community paramedicine program from Meds One EMS is providing health care to individuals who have one or more chronic medical conditions, or people who have been seen in the emergency department for typically non-urgent situations, non-urgent events. And also people that have issues related to just generally managing their medical support at home. We provide the service as a referral from a number of agencies, generally through the primary care provider, to go out and provide assessment to that individual and to help the person maintain their independence and improve their health care.
Fantastic. I'm excited to hear more about this wonderful program.
Thanks.
ElderCircle Forum is brought to you by the following community supporter.
Globe Drug and Medical Equipment. Globe Drug is a full-service pharmacy and medical supply store carrying home oxygen, sleep apnea, and other respiratory supplies provided with the assistance of an on-staff respiratory therapist. Globe Drug and Medical Equipment in downtown Grand Rapids, your neighborhood pharmacy.
Hi, I'm Kristi Kane, Executive Director of ElderCircle. Welcome to ElderCircle Forum. At ElderCircle, we work with our area aging community members to keep them independent, active, and in their homes as long as possible. I have with me today Tim George from Meds One Ambulance Service. Welcome, Tim. Thanks
Hi.
for coming today.
Thanks for having me.
Tim, you've got some interesting roles that you play in the community, and one of them is community paramedic for Meds One Ambulance. But before we talk about that, can you tell me a little bit about yourself?
Well, I've been in emergency medical services since 1978 and paramedic since 1982.
Okay.
And through that position, I've moved into a position as Director of EMS and Community Health Outreach for Meds One. I'm born and raised in the area. A lot of connections, a lot of ties to the area. And,
you have some interesting hobbies, don't you? If I remember, are you a mountain climber?
Rock climber. So trying to stay away from the mountains. It gets a little bit thin up there, but yeah, rock climber, and I do a lot with backcountry medicine as a connection to background related to trip leading. I also, at one time, for a period of 10 years, mushed sled dogs.
Oh, wow.
And did a lot of winter tripping.
Okay.
A lot of people think it's kind of odd that I like camping in the winter time and without a tent, those type of things, but it's a nice carryover, especially with the younger children right now. My son is 13, my daughter's 10. Both are interested in outdoors.
And have you taken them yet, camping in the winter?
We're this summer planning a trip to the Boundary Waters with my son. My daughter's not so much interested in that type of tripping, but she's doing a lot of work with camps right now and going to camps. So probably going to build into that.
Fantastic. So has your medical background come in handy as a parent?
Well, I would probably be considered to be not the model of pediatric medicine practitioner in my household. When it comes to my kids, I think I get a little bit more concerned about the smaller things that happen with them, and probably a little bit more stress, like most people probably would with their kids. But as my son is getting older, a little bit easier to work with injuries and stuff that happens with athletics, etc. But no, I'm a little bit more of a helicopter parent when it comes to those things. My wife's a little bit better at this than I am. So
I always thought that I was very calm and could handle any situation, any amount of pressure, until I saw my child bleed the first time, and then I was a mess and no good to anyone.
Yeah, it's that the thing that's called the Great Wall, when you get into a situation where you have some type of emergency happen, and all of a sudden you start magnifying all the things around it that you think that are going to be a result of it. Happens out with the backcountry when people are in the boundary waters or taking long trips, or with expedition medicine. Little injuries all of a sudden become magnified, and so when we teach that type of health care, that type of medicine and emergency care, first aid programs, whatever, we try to help them understand how to work through all of those emotions when it comes to that. Except when you're the parent in your own house as a paramedic with 30 plus years experience, it's like I'm not going to be able to usually follow my own recommendations then.
So tell me a little bit about Meds One first off.
Well, Meds One is a private corporation that operates an EMS agency and ambulance service in the greater Grand Rapids area. We have a 1,028 square mile service area that is set up through the state of Minnesota's Emergency Medical Services Regulatory Board. And that service area, it's called a primary service area, is a sole responsibility with the population that's within that area of our service for emergency medical service response. We provide advanced life support, which is provided through paramedic personnel. Paramedics are at a minimum undergraduate level educated and board certified as paramedics. We also have emergency medical technicians who work with our paramedics as partners, and we respond to upwards of 3,000 to 4,000 calls and responses a year, depending upon how we want to rate those. We provide services also at standby for events without ambulance available. We have other type of response vehicles that are a track vehicle, a Polaris, as well as a golf cart, those type of things, to allow us to cover certain service areas. Just recently we provided service at the lacrosse shootout out at Rutgers, and during that time period we provided service to over 80 injured individuals.
Really?
Well, 800 people showing up to be participants, or 800 plus. Excellent program that they have around here for lacrosse. One of the biggest lacrosse shootouts that you're going to find around the Midwest for the age groups that we're looking at. And there's certainly a potential for injury. So not all those injuries required any type of health care following our assessments and treatment. I think we only transported several up by ambulance, which is a pretty common thing with contact sports when they have that number of people.
That's interesting.
Yeah.
So Meds One has been in the area how long?
Since 1978.
Okay.
We're coming up upon our anniversary next month for service in the area. Previous to that, there was a service called Northland Ambulance Service. It was a family-owned service. Services in Itasca County, as much of Minnesota, were initially county-based or county-supported services. In Itasca County, there's been continuous support over the years. We severed our relationship related to that support with ambulances and subsidy in 2010 so that we could structure our services a bit differently. But the services that are in Deer River, in Big Fork, and in Nashwauk utilize subsidies as well as ambulance support dollars to buy ambulances for their community. Okay.
Now, Meds One has been doing something recently called Community Paramedicine.
Yeah, Community Paramedicine.
All right, which you are a part of, and which I understand is kind of a rare service.
Well, Community Paramedicine, it takes its name actually from the area Queensland in Australia, where a person would be living in a distant community in the outback. They would have their primary care provided by somebody that is a specially trained paramedic. Okay. And that paramedic is called the community paramedic. And when you look at community health care and community needs, it was a natural transition in this country to use that term to describe a paramedic with more advanced training in primary care, social service support, as well as what we look at as ability to assess what's called determinants of health, those things that all impact a person's ability to either gain health care, manage their own health care, and also affect their health in general. And there's many ways to look at that. Later on, at the end of this presentation, we'll have some addresses put out for the internet that can describe a little bit more about community paramedicine across the world and across the country.
But there are not that many in Minnesota, correct?
Right now we have about 30 licensed community paramedics. Meds One has 3, myself, Alyssa Hughes, and Jim Battaglia are 2 other paramedics that work with us and have a significant history in EMS, and have also gone back to gain the education and credentialing licensure for the process that we provide. What we do with community paramedicine is a bit different than is being done, say, by Alina in the metro area or by North Memorial in the suburbs, which are probably 2 of the larger community paramedicine programs in the state. Their programs connect the community paramedic directly with the primary care provider, and they follow patients from clinic visits. In between clinic visits with patients with chronic medical conditions. Our program here, because of the rural nature of the area and the aging population, is more involved with the vulnerable patients, the patients that maybe are slipping between the gaps of the healthcare system. Sometimes because of issues that they have that are going on in their life, they're determinants that we call them, as well as sometimes just unassessed diseases that they have, or diseases that are being poorly managed by themselves and maybe poorly understood even by the healthcare system that they're working with because of the lack of contact with clinic visits.
What prompted Meds One to move in this direction? Yeah,
interestingly enough, it goes well before the movement in this country related to community paramedicine. We've always had a strong connection with community health, largely because of a connection with the public health service and community health services in the county. So with Itasca County Health and Human Services being the connection that we had originally with the contracts that we had, we were called upon, because the very nature of what we do as paramedics, to assess patients occasionally that they wanted to have a little bit more understanding of related to what was going on in their household, etc. That would happen on a rare occasion. Also, we have a very strong connection with the behavioral health community, especially the crisis response team that the county has available. And with that, we have probably for the last 12 years done some things hand in hand with some of the leadership with CRT program, the crisis response team program, to provide primary care assessment on patients that they've gone out to evaluate for behavioral health concerns. So it's kind of been a nice partnership.
Okay, so explain to our viewers what primary care assessment is.
A primary care assessment would be the same type of assessment that you'd receive in a clinic when you go to see your primary care provider.
Okay.
So the extension of community paramedicine under state statute extended us as extenders of primary care.
Okay.
So ideally, and that's where reimbursement would come through, say for instance, medical assistance programs and insurance, would come through referrals from the primary care provider. When a primary care provider, your physician, your nurse practitioner, your PA would like us to go see a patient with chronic medical conditions in between those clinic visits where there's a concern of compliance related to medications, wound care where a wound care nurse is not involved, or maybe in a situation where there's a suspicion that a person might need some more involvement with home care, home health care. We will extend those providers into that person's household and be their eyes, their ears, and the ability to also transfer that assessment back to them in the form of a patient care report that they can evaluate, and they can decide how to manage that patient from a distance. Not unlike emergency medical services has evolved in this country since the 1970s, where we're extending the emergency department to the community right into your home or into a motor vehicle crash.
So my understanding as a provider in the community is the people you see are often people that have had maybe multiple calls to the ambulance or multiple emergency room visits in a short period of time, and part of your role is to go and assess why this is happening.
Yes, and to develop a plan with the primary care provider along with public health or health and human services or other partners such as your organization to work a care plan out that would benefit that individual. Ideally, the legislature in 2011, when they passed the community paramedic bill, they passed it with the intention of also decreasing cost to the end third-party payer, which would be medical assistance in a large part of this, and also Medicare. Medicare hasn't quite picked up the role of paying for this yet. Medical assistance has.
Okay.
And our role in Itasca County has been more of the incipient stage referral source, which means we were the ones that are going out first and managing the situation, and then referring back to the primary care provider. We've been working with Essentia physicians more in the role that we are seeing more in the metro area, where they're telling us that they have a patient that needs to have an evaluation, and then we'll go out and evaluate those patients and report back.
And so how long have you been offering this service?
We've been offering this service since 2013.
Okay.
So we're only in our second year. And since that time period, it's been well accepted by most of the primary care providers. However, the referral sources right out of the clinics have not been at the level that you might expect in a rural area. Most of our referrals are actually coming through the Itasca County Health and Human Services or through other care agencies.
Okay, that's what I was going to ask you. Who refers you and who can?
Anyone could ask for their primary care provider to ask for our services, and that's intentional with the statute for reimbursement. Solely, it would be best that a person would, when they had an individual that they were concerned with their health status, go through an official agency, the home care services, to ask us look at somebody, home care nursing, public health nursing. If they suspect that a person has a level of vulnerability that places them into the category of a vulnerable adult, definitely to what we call the common entry point, which is the Itasca County Health and Human Services entry point.
Okay. So when you go into people's homes and a referral's been made and you're going in to do an assessment, what types of things are you looking for?
Well, interestingly enough, we're not looking at the person at the very beginning. We approach our assessment like we do when we approach a motor vehicle crash, or how we approach a situation where a person's having a medical emergency in a home. We look at, first of all, what we call a scene assessment. And in the scene assessment, we're looking at it quite a bit differently like that we would in a motor vehicle crash. Definitely we'll look for dangers. And there are definitely dangers in residences that we respond to. Some of those can be the determinants that are causing the problem. We've encountered carbon monoxide issues in residents when we showed up there that have actually created medical concerns for a person. Definitely we've encountered a wide variety of other things, including just structural issues related to people's residences. But we'll look at that, and we'll look at general safety issues. We'll look for fall hazards. Same thing that you could do if you walked into a residence and you have a person that had a problem with their mobility. And fall hazards would be something as simple as a throw rug. Throw rugs can actually be a killer. If you have a person that falls, injures themselves, and is on a medication, for instance, that changes their blood clotting capability, you could have a person have a head trauma from a person just falling and tripping on a throw rug. And we have seen that. That's something that's not an uncommon situation. So throw rugs, the ability of a person actually to get around through the residence. And then looking at the residence, what is that telling us about how the person is living? We have the ability to use, interestingly enough, ultraviolet light assessments in a residence, some things that you see on CSI where they're looking for blood splatters and that. We'll see if there's patterns in the residence related to the person's movement, because that produces trails. If people have problems with issues related to managing toileting, that type of stuff, we can actually witness that too. Sometimes it's obvious, sometimes it's not so obvious. And that brings us into conversations with the patient about their day-to-day life. Generally speaking, we'll spend an hour or so with the patient, something that they don't get a chance to do in a clinic just by the nature of how our healthcare system is set up.
And you don't drive up in an ambulance.
And we don't drive up in an ambulance. We do respond in vehicles that have all the equipment that the ambulances have, and we utilize some of that equipment. Interestingly enough, in emergency medical services, especially in advanced life support and critical care, the medication and the technology is huge. we don't use as much technology. We
Okay.
will do a complete exam. We'll use an otoscope, which is the device we look in ears with. We'll use an ophthalmoscope, which will look at the retina, the eyes in some cases. We'll look at skin patterns. We'll look for signs of injuries that the person may not report.
Okay.
That tells us if there's problems with mobility. Then we'll do a screening exam for mental status in many cases. It depends upon the report, depends on the problem. We use real objective mental status exams that tell us if there's issues related to the person's memory.
Okay.
And then EKGs, things like that are naturally something that we have available. So it depends upon the case, we might do an EKG on a person.
Now, while you're there, we often see people who through multiple visits have acquired different medications, and sometimes things are counteracting each other and they haven't had a good med review. Is that something that you can take the time to do?
Yes, and that's all part of it too. Every time we go out, we do what's called a medication accountability assessment, and it's just a matter of inventorying the medications, and then we look at the dates the medications were prescribed on, and then we will determine if they're actually being compliant or taking the medications when they're supposed to take them. And many times we'll find that will lead us into other questions related to memory issues, also determinants, as we say, related to their finances. People, many times we will see people rationing medications, and that will tell us, well, there's a potential need then for some other type of assistance in the community, and we have the ability to actually refer and make partnership between that patient and also other referral sources within the community. And always, if we find any of these situations like I was describing that are remarkable, we'll make sure that the primary care provider understands that.
Okay. We had a conversation earlier talking just about a couple that were living together, and one had memory loss and the other one didn't, but the person with memory loss was physically very able and capable, and the other person had loss of mobility. And in my field, we see that quite often, where people are taking care of each other, and not always married couples. Sometimes it's neighbors or friends that kind of form a bond like that, and as they're aging, help each other get through the process. And that's a wonderful social support. But when that is gone, it often leaves one person very short on abilities. And so how often do you come across situations like that? And
generally on a weekly basis, we'll see this. And that creates a significant level of vulnerability for patients that have chronic medical conditions, especially those that have chronic medical conditions paired with some type of memory loss or dementia. And then when we see that, it's great when we have the churches in the community or the neighbors taking care of somebody. But what happens is when that relationship is severed for some reason, and sometimes it can be severed just because individuals become fed up with managing situations of a person's mood or behavior changes.
Yep.
And then all of a sudden they retract their care support. We call these informal support systems. And when we see these informal support systems, they can be this dual-edged sword, as using a real old used metaphor, but they can be wonderful on one side, and on the other side they can be probably the worst thing that's happened to the person when they get severed. So it's something that we have to identify, and that's one of those things that we ask people to look at, where when you see that social support system of a spouse or a neighbor caregiver change, that's when the identification of a person's healthcare status should be looked at, and see how those changes are occurring. And so with loved ones, say for instance, living in a distant area, and they're talking to their parent on a weekly basis or on a monthly basis, one of the questions that we ask people to ask is, how is the neighbor? Are they still around? Or and then when the death does occur in the family, for instance, of the spouse, there's going to be not only the depression that's going to probably set in at that time and the loss issues, but we're also going to see the definite changes in how people can manage their medication, how people are going to manage their appointments. Something as simple as where do they get the medication from? And so, on a weekly basis, and sometimes more often than that.
Which brings up another question. How many How many people do you think you see in paramedicine on a weekly basis?
Lately, it's been almost 4 to 5 a week.
Okay.
4 to 5 a week. And of those, probably half are repeat visits on top of that, where we'll go in, assist in making a change, develop a connection with a partnership. It could be ElderCircle, it could be a home care agency. I make a lot of appointments for physicians, physician visits, with the patient or the family member, and to make sure that that compliance has been, developed with that individual or with the family member, etc. And sometimes it has to do with just wanting to check on the person to see if they've fallen again.
Okay.
And we'll do this with just the regular EMS responses too. If someone falls and is in a residence, is uninjured, we want people to call us. It's going to be one of those situations where we'll respond. There's no charges that are going to be presented to the insurance company if it's just a fall. But if it's a fall and the person isn't able to manage their ability to be mobile in their household, given the type of environment they have and the type of the mobility supports they have and their general health status, if they fall again, that's going to trigger a different response from our agency involving the community paramedic program, and in a lot of cases human services, and response back to the physician stating, this isn't something that shows up on an electronic medical record, so we're going to have to actually have a connection with their physician or the physician's nurse and have the conversation to say, your patient has issues that probably should be looked at.
It's interesting when you're talking, because there's a lot of behind the scenes partners in community health, and and I think we forget sometimes, and you think, well, I can call the ambulance and there's a doctor and a nurse, but there are so many more people involved. And also, when we were talking earlier, you talked about you have a local physician that oversees all of your community paramedicine reports. Is that correct?
Yes.
And plans?
By statute, in Minnesota and in most states, EMS agencies have to have a medical director that's a physician medical director. In community paramedicine, it's also a mandate under statute, and this medical director becomes the medical director partner of the community paramedic.
Okay.
And whether that physician is there or not, we work through the case together. It may be after the fact. It also may be contemporaneous or during the time that we're actually at the scene. Less often than that, though. It would be more common to actually review the case and get advice, especially if it's going to be a repeat visit. And before I came here this morning, I was reviewing several cases. Dr. Peter Friedlieb, some people probably from the audience remember him as being internal medicine physician with Grand Itasca. He is our medical director. He maintains his license as a physician, and he is a consulting medical director and a medical consultant right now after his retirement from that clinic. And so we are never away from a physician when it comes to the evaluation of a patient and the planning for a patient.
Now, I've been asking you questions and really talking about this interview as if community paramedicine were for our aging population, but really I would assume you're seeing people of all ages if there's a need.
Well, community paramedicine's expanding in Minnesota. During this legislative session, I don't know where it has gone yet. I've been watching the C-SPAN live runs of the legislation, looking at the changes in the omnibus bills, but there is a desire to advance community paramedicine, especially in the metro area, with health and human service evaluations for child protection.
Okay.
And one of the things as community paramedics that we can provide is if there is potential for abuse, we can provide wound pattern assessments that can't be provided directly by the human service worker that's on scene.
Okay.
And many times it's better to see also those environments of health that determinants in those situations. But community paramedicine goes across all age groups, across all areas of the population. We specifically, though, are looking at the vulnerable population, people that have multiple health risks, chronic diseases, multiple medication issues. As you mentioned, the medication compliance is a huge, huge issue. Just knowing that you can go out and educate somebody on what the medication is that they're taking and what it's for. A lot of people think that they're taking a medication for one reason when it's actually being given to them for others. And then also the competitive nature of medications, the things that medications do to each other and do to the patient. Those things have to be looked at. We have referral support through pharmacy people. And we can also, advise individuals to go and have a reevaluation by their physician related to the meds.
As I might be way off base on this, but as an ambulance service, Meds One is also a licensed pharmacist?
We actually have a wholesale pharmacy license.
Okay.
It's intentionally part of our business model that maintains lower costs for the medications that we gather.
Okay.
And then some of the people in the community probably recognize our agency as supplying most of the dental offices with the medical gas that they use, the nitrous oxide and the oxygen.
Okay.
And that helps, again, decrease our cost and increases our access to that. But it also, interestingly enough, increases our access to individuals that can help us as consultants and partners related to, understanding
absolutely.
Medications more.
I think we're lucky in Itasca County really to have an ambulance model that has such a mission for community medicine and making it affordable and available to everybody.
Well, thank you. I have to say, when I was writing the paper for the community paramedic program, when I was going to school for that license and that certification, we looked at this community. We looked at Itasca County in comparison with the other counties in the state and across the country. We were partners in school with our class partnership was pretty broad. People from above the Arctic Circle in Canada, Nova Scotia, Bar Harbor, Maine, Missouri, were all part of that aggregate group of students that we were going to school with and graduated with. And we all did a comparison, and I feel blessed living in this county with the partnerships that we have available for vulnerable populations, the partnership we have available with the human service model that's available here. And also, just looking at Itasca County Health and Human Services, it is above all the other human service programs that exist across the state as far as their proficiency and efficiency and their quality of managing the cases they have to manage.
Yeah.
And so we're lucky to have ElderCircle.
Yeah, well, thank you.
And ElderCircle with Community Paramedic Program has been I believe a fantastic partner in decreasing a person's ability to have their chronic medical conditions and the aging, etc., create more problems for them, and that creates independence.
Yeah.
And one of the things that we look at with community paramedicine is when we talked about the assessments we look at safety being the primary issue, but we also look at dignity. And ElderCircle does a wonderful job maintaining that for individuals here in this community.
Well, thank you. Well, the goal for both of us is independence for our population and health and wellness. And so we're going to have to wrap up here in a few minutes, Tim, but you had mentioned a couple resources that would explain community paramedicine a little more in depth. Can you tell me those sites?
There's a website, communityparamedic.org,
Okay.
and that website is the website that is run by the International Community Paramedic Roundtable. Community paramedicine is an international movement.
Wonderful.
Interestingly enough, Meds One was on the initial point of creating that roundtable. Kevin McNichols has been a champion for community paramedicine, my CEO for Meds One, and I believe a board member of ElderCircle.
Yeah.
And he started the community paramedic approach to, I guess the approach to get the legislation in Minnesota, along with some other leaders across Minnesota. But that will explain the intent and the partnership, the education programs that are there, and the legislation, et cetera. And that focuses on the U.S. generally, but also does cite some links that will look at it across the country as well as the world.
Okay.
And then there's another, and I don't have that site memorized, but it's a national legislative website that has information. If you just look in the search engine on that site,
And we'll post that
yeah,
website.
and look up community paramedic, it has many reference points that explains the process, the background, etc. It's not just something that was created here. This is something that we've looked at and modeled a previous program to develop into, and it's probably, I believe, and it's cited in that site by the legislative body, that the group that put it together, as probably one of the most innovative approaches to community health care since EMS was developed. And EMS was developed because of neglected diseases that happened outside of hospitals and outside of clinics. And we're just expanding into a role that I believe is natural and nowadays needed. And,
That's right.
and if we can keep people independent and healthy, then the community is going to be independent and healthy.
That's correct. Well, thank you so much for coming on today, Tim.
Well, thanks for having me.